Oh, you're still here. Great. Well, I'm going to talk a little more in depth about each of the dissociative disorders. In DSM-IV text revision, there are 5 different disorders in this category. There's depersonalization disorder, dissociative amnesia, dissociative fugue, dissociative identity disorder, and dissociative disorder not otherwise specified. Depersonalization is the feeling of being detached from or not in one's own body. The person might experience sensory anesthesia. They might fail to recognize their own image or reflection in a mirror, and they might have the sensation of lacking control over their body or not being responsible for the actions of their body. An important thing to consider with depersonalization disorder is that the individual understands that this is a feeling or an unusual mental health event that they're having. Their sense of reality testing is intact. Depersonalization is a common experience. So to diagnose depersonalization disorder, symptoms need to cause marked distress or impairment in order to consider a diagnosis of a disorder. Now, individuals with depersonalization disorder may have secondary symptoms of depression or anxiety or other mental health concerns. They may experience feelings that they're crazy because of the depersonalization that they're experiencing. And if a person reports experiencing recent trauma and that they're having feelings of depersonalization that come with that and they don't have a history of other dissociative behaviors, you may consider a diagnosis of acute stress disorder instead. The criteria for depersonalization disorder are persistent or recurring experiences of being detached from, and if one is an outside observer, of one's mental processes or body, such as feeling like one is in a dream. During the depersonalization experience, reality testing remains intact. The depersonalization causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, and the depersonalization experience does not occur exclusively during the course of another mental disorder, or it is not due to the direct physiological effects of a substance or other medical condition. Dissociative amnesia. This is the inability to recall important information that's usually related to a traumatic or stressful experience. It's considered a reversible, retrospective gap or gaps in memory. Now, acute dissociative amnesia may resolve itself once the person is removed from traumatic experiences. Examples of this may be a veteran who has no recollection of a battle that they were in recently, but after a few months back home following their deployment, those memories begin to return to them now that they're no longer in that stressful circumstance. Just as depersonalization disorder, dissociative amnesia may be accompanied by secondary symptoms, depression, anxiety, or other dissociative symptoms or functional problems. Dissociative disorder has several types which clinicians should be familiar with. There's localized amnesia, which is the inability to remember a discrete period of time, usually surrounding a traumatic event. Selective amnesia is when an individual loses some, but not all of their memories or information about a time surrounding a specific event. Generalized amnesia is when an individual has a failure to recall any information whatsoever, their name, their experience, how they got where they were today. Imagine an individual checking into an emergency room with no idea whatsoever where they are or how they got there. Continuous amnesia is when an individual has a failure to recall any events from a particular point in time up into the present. And systematized amnesia is the inability to remember events and details or information in certain categories, either regarding a certain event or regarding certain experiences following that event. The criteria for dissociative amnesia is first, the predominant disturbance is one or more episodes of an inability to recall important personal information, usually of a traumatic or stressful nature, that is too extensive to be explained by ordinary forgetfulness. The disturbance does not occur exclusively during the course of another disorder and is not due to the physiological effects of a substance or a neurological or medical condition. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of function. Dissociative fugue. As a note, dissociative fugue is going to be wrapped into the category of dissociative amnesia in DSM-5. The fugue state will be considered a feature of dissociative amnesia and not requiring a specific diagnosis. The primary disturbance of dissociative fugue is a fugue state where a person unexpectedly travels away from their home or customary place of work or business and has an inability to remember their past. They'll also demonstrate identity confusion, assuming a new full or partial identity. The criteria for dissociative fugue: the predominant disturbance is a sudden unexpected travel away from home or customary place of work with inability to recall one's past, as we just stated. A confusion about one's personal identity or assumption of a new identity, partial or complete. The disturbance does not occur exclusively during the course of dissociative identity disorder, and it is not due to the direct physiological effects of a substance or general medical condition, and as the symptoms cause clinically significant distress or impairment. The dissociative disorder that most people are familiar with is dissociative identity disorder. This was formerly known as multiple personality disorder. It involves the presence of two or more distinct personalities or identity states. And these changes between identity states affect behavior and the recall of information. It's important that there is amnesia, or a failure to retain information that's gained in one state when the personality changes to another state, in most instances. The primary identity, which usually has the person's name, is often passive, depressed, dependent, or guilty. The different identity states may deny knowledge of the other states, or they may be in open conflict with each other. More powerful states may allow time for other personalities to emerge. In dissociative identity disorder, dormant personalities may speak to or offer information to the active personality in the form of visual or auditory hallucinations. People experiencing dissociative identity disorder may have irregular amnesia. More powerful personalities typically have more complete memory, while less powerful ones experience more amnesia. Individuals with dissociative identity disorder may experience a variety of other symptoms or disorder states at different times, including conversion disorder, PTSD, substance-related and other disorders. Different personality states may show the effects of different disorders that are not present when other personality states take over, particularly conversion disorders where they affect certain physical symptoms or ailments that the other states do not have. So, in summary, the criteria for dissociative identity disorder is the presence of two or more distinct identity or personality states, each with its own relatively enduring patterns of cognition, perception, and behavior. At least two of these identities or personality states will currently take control of the person's behavior. The person has an inability to recall important personal information that is too extensive to be explained by ordinary forgetfulness. And the disturbance is not due to the effects of a substance or general medical condition. Note that in children, the symptoms of dissociative identity disorder cannot be attributable to imaginary playmates or fantasy play. Lastly, there's a category for not otherwise specified dissociative disorders. This is for individuals that have dissociative symptoms that don't meet the full criteria for one of the listed diagnoses, even though the dissociative condition is the primary concern that they're experiencing. In DSM-IV text revision, a person who experiences derealization, the sensation that the world around them is not real, that they're maybe living in a video game or a movie, would be diagnosed with dissociative disorder, NOS. In DSM-V, they would be diagnosed with depersonalization/derealization disorder. Looking ahead to DSM-V, there are some changes to the category of dissociative disorders. Derealization is included in the symptoms of what is now depersonalization/derealization disorder. Dissociative fugue is now a specifier of dissociative amnesia rather than a separate diagnosis. And for diagnosing dissociative identity disorder, symptoms can be reported as well as observed, and gaps in recall may occur for everyday events rather than specific to traumatic events. and the criteria for dissociative disorder have been expanded to include more culturally diverse presentations, such as possession form phenomena or functional neurological symptoms. Some of the challenges for making a diagnosis of a dissociative disorder are that individuals who meet the criteria for dissociative disorders often score very highly on measures of hypnotizability and suggestibility. Individuals may be presenting with symptoms that they had learned about through the media or other states, or maybe malingering as well. It's an important thing for individuals to consider when making a diagnosis, because malingering dissociation may be common in individuals who present with acute symptoms, particularly with a very florid or dramatic presentation when potential gain is evident. Also, it's important to consider that memories that are recovered from amnesiac states can be unreliable. Childhood memories are unreliable as is, but memories that are recovered from an amnesiac state may be doubly so, and may be influenced through the recovery process or the treatment process. Increases in dissociative diagnoses in the United States may be a result of increased clinical awareness, adoption of symptoms by suggestible clients, and malingering behavior, or all of the above. So I'd like to take a moment to talk about treatment for dissociative disorders. Because dissociative disorders are so closely tied to the traumatic events or experiences of abuse or neglect that an individual has experienced, really the treatments for dissociative disorders are treatments that address the trauma or the affect dysregulation that an individual experiences. So the primary treatments are psychotherapeutic in nature. Individuals may participate in direct treatment for trauma, such as trauma-focused CBT or other trauma treatments. They may participate in treatments like creative arts therapy or other sorts of treatments that are trying to address their ability to be mindful and aware of their emotional states, and to help to teach them coping skills to manage the affect experience. For individuals who have clinically significant symptoms of depression, anxiety, or other mental health concerns, medication may be used to help treat those experiences. Some individuals who have trauma-based disorders may also take medication to reduce nightmares or to improve their sleep. I hope you found this presentation on dissociative disorders useful and informative. We hope that this provides tools for clinicians to evaluate patients with dissociative symptoms and make effective diagnoses that will lead to relevant and impactful treatment for those clients.